Can you see my slides? Okay. So our goal is to both identify and initiate treatment for common symptoms. And these are the 4 that we'll try to get through. Helen, realistically, how much time do I have?
So we want to get to the case discussion for sure.
Which is going to be then.
Yeah, and so I mean we can do 45 minutes. I think that's okay.
Okay.
Is that, yeah.
All right, I'm going to set my watch for 45 minutes. Okay. So we're going to start with a case, and this is Mr. B. He's 79 years old, follow-up for back pain, now here for diarrhea. He has metastatic prostate cancer to bone. He's on amlodipine. He was just started on MS Contin a week ago for the back pain, along with Colace. His physical exam is normal, except for moderate distension and tenderness and a fecal impaction on rectal exam. So the predominant symptoms are straining and abdominal discomfort. The prevalence is unbelievably high. 65% of community dwelling adults over age 65 meet criteria for constipation. So it is more common than not in many of the patients you take care of. So being hyper aware of it and concerned about it is important. So why should we care about something that's so common? Is it important? So aside from the fact that it's highly prevalent, it is associated with anorexia, mood disorders, and functional decline. If anybody has ever been constipated, you're probably too young to have experienced that. But if you have, it affects every aspect of how you feel. When it is unaddressed, it leads to fecal impaction, that is a collection of stool that is stuck essentially and blocks the bowel, leading to a functional bowel obstruction. If that goes on long enough, the bowel actually ulcerates from the pressure of the stool and the toxicity of the stool against the mucosa and can perforate and cause death. And about 15 years ago, I was attending on the medicine service, and on the house staff service, we actually lost a patient who died from this complication, no one having noted that he hadn't had a bowel movement since admission, and he had been in the hospital for 10 days. So, you know, this really happens, and unfortunately, it is our responsibility to monitor for that and prevent it. So the basics are to ask about whether the person is having regular bowel movements, and also ask about things that are most concerning, like have they had any blood in the stool? Is there any inexplicable anemia? Is there weight loss? Is there an abdominal or rectal mass? And the physical has to include a rectal exam. You can't determine that someone has a fecal impaction through an abdominal exam. We were talking about cost effectiveness a little bit earlier. The standard lab tests are to look for anemia, evidence of diabetes, hypothyroidism, hypo or hypercalcemia. The evidence says ordering these things, of course, we're ordering them anyway, but they're not cost effective specifically for constipation. Colonoscopy is really only indicated in the workup of constipation if the patient is refractory to aggressive laxative therapy, if they've had an abrupt change in bowel habits, or if they're at the age when they should be getting colonoscopic screening but didn't get it. And the takeaway, like most things in medicine, is that prevention is key. So the first steps in management are bowel retraining. And what do we mean by that? There's something called the gastrocolic reflex that when in the morning, when we first eat or drink something, there is the gastric distension sends a signal to the rectum to evacuate. And if we obey that signal and evacuate after breakfast every morning, it starts to retrain the bowel into a schedule. So important to tell patients about that, not to hold it when they feel the urge to go. People need to have adequate fluid intake. They need to be active. They need to be eating a lot more fruits and vegetables than many of our patients can afford or have access to. And then you move to prescribing interventions. So let me ask you what you think the number one reason is for inadequate response to laxatives. Does anybody have a thought of what that might be?
If nobody wants to give us their thoughts, I can chime in that not having the correct laxative, because there's different laxatives have different mechanisms, and sometimes we add on multiple laxatives with the same mechanism. So bulk forming laxative, stimulant laxative. So we need to have a laxative regimen which actually complements the two complementary agents rather than adding on the same kind of laxative.
Right. So the number one reason is that we don't prescribe them properly. We don't give enough. So we'll order Colace and think we've ordered a bowel regimen. And we don't give the right types and range of laxatives. And as will be repeated several times in this talk, Colace is no better than placebo and should not be prescribed. It is not an effective laxative. There is no difference in randomized controlled trials between patients who get Colace and those who don't in terms of laxation. So we have to get over that kind of reflex habit of ordering Colace because it's a waste of money and time. So this table, you guys hopefully will get a copy of this. The ones I want you to pay attention to because they are the most effective in our patient population is Miralax, which is polyethylene glycol powder. It's a powder, you mix up a scoop in 8 ounces of water and you drink it once or twice a day. And then the other category is stimulant laxatives, bisacodyl, either tablets or suppositories or Senna. Prunes and prune juice are also very helpful. These two categories will almost always be sufficient. If you use enough of it and you don't stick to a single category. Don't use stool softeners. Don't use prokinetic agents. If somebody has an impaction on rectal exam, you need to try to disimpact both manually through the use of Dulcolax suppositories, bisacodyl suppositories, and enemas, and warm tap water enemas. What kind of enema should we never be using in older people? Actually, in anybody, children or older.
Phosphate.
Fleet's phosphosoda kills people, causes hypocalcemia and arrhythmia. Do not use. Use just warm water. So if you've got a patient who's on opioids and opioid treated patients almost universally develop very difficult to manage constipation. Again, prevention, prevention, prevention. Never write a prescription for an opioid without simultaneously writing a pretty aggressive bowel regimen prescription. So that you prevent the impaction that otherwise will occur. So there's this relatively new treatment, which is a receptor antagonist that only affects the opioid receptors in the gut and is not absorbed. So it doesn't adversely affect the patient's level of analgesia, and they don't go through opioid withdrawal because it only affects the bowel receptors. So it's methylnaltrexone, which is sub-Q, and naloxegol, which is oral. However, it is $55 a dose, incredibly expensive, and routinely leads to pretty significant abdominal cramping and nausea and vomiting. If you've aggressively tried the agents that I mentioned before and you haven't been able to get a response, that's the appropriate time. I think you have to request permission to use this drug from, is it pharmacy? Who do we have to request permission from?
It's usually either GI or us.
Oh, okay, good. We're happy to give it. This is just a cost comparison, just so you see. So for example, secretory drugs like lubiprostone or linaclotide, $290 a month. Polyethylene glycol, $18 a month. Lactulose, unbelievably expensive. $144 a month. So remember that even if your patients are covered, they are paying copays and deductibles. So when you order these drugs, you have to think about their cost in addition to their efficacy, because the burden often falls on your patient. So to cut to the chase, just tell me what to do. Step 1, make the diagnosis. Step 2, stop anticholinergic drugs if you can. And there are many anticholinergic drugs that we don't think of as anticholinergic drugs. So there's an app called the Anticholinergic Burden, I think it's ACB, that lists all the drugs with anticholinergic side effects and gives them points as to how anticholinergic they are. Check your patient's list, because many drugs we don't think of also have significant anticholinergic toxicity. You have to do a rectal exam. You have to rule out fecal impaction. If the impaction is present, you must disinfect, do those tap water enemas, provide glycerin suppositories just to lubricate the anorectal region until results. Never give laxatives from above in a patient with an impaction. What will happen? Just fluid and pressure above the impaction, no results. If you don't eliminate the impaction first, laxatives are actually harmful and may cause vomiting, aspiration, worsening distension. Hydrate the patient, increase dietary fiber, and prescribe. I usually start with Senna, 2 tabs at bedtime. If no results, I go to 2 twice daily. If that doesn't work, I add the Miralax. The reason I don't start with Miralax is because it's sometimes hard to get people to drink that 8 ounces. You have to dissolve this in a lot of fluid for it to work. Again, I start with once a day, then add twice a day. And if that doesn't work, I use Dulcolax suppositories after breakfast, again, to take advantage of the gastrocolic reflex and try to stimulate evacuation. It is the rare patient where these 3 steps will not take care of the constipation after you have disimpacted the patient. So moving on, Mr. B also tells you during the visit that he's been too short of breath to walk to the mailbox, and this is really bothering him because that was his daily ritual. So what is dyspnea? It is a subjective experience of breathing discomfort that consists of qualitative sensations that vary in intensity and are hugely multifactorial. There's no single cause. It's common in patients with all serious illness, not just those with COPD or pneumonia or emphysema or heart failure. People with frailty have dyspnea. People with cancer have dyspnea. People with HIV/AIDS have dyspnea. People with dementia have dyspnea. And often there are combinations. So we need to pay attention. Actually, dyspnea is more common than pain across the serious chronic illnesses. So here's a quick quiz question. The diagnosis of dyspnea requires which of the following to be present? Labored respiration, respiratory distress, hypoxia, increased work of breathing, hypercarbia. So I think I've already given you the clue answer to this question. The answer is none of the above. It is subjective sensation of feeling short of breath. You don't need any objective findings to make the diagnosis of dyspnea. It's a distressing subjective symptom like pain, which has no reliable physiologic correlates. So if the patient says they're short of breath, they're short of breath. Self-report is the only reliable measure. And in Mr. B's case, remember he has metastatic prostate cancer. Which of the following are the most likely cause of his symptoms? Anxiety, a PE, that's certainly possible, an MI, that's possible. Serious illness-related dyspnea, much more likely. Occurs in over half of patients living with a serious illness. You got to rule out those other possibilities. New onset of dyspnea is a serious symptom and deserves a workup, but the Likely diagnosis is it's accompanying his general physiologic decline, serious illness-related dyspnea. Mr. B's wife mentions that since he started having trouble breathing, he has been down and has had difficulty concentrating. She's asking about an antidepressant. Which of the following causes best explains his emotional and cognitive changes? Depression, anxiety, dyspnea, or early dementia? Any guesses? So the answer is dyspnea. People who are short of breath have a very high prevalence of co-occurring anxiety and depression. It's not entirely clear whether the causation direction is dyspnea causing these things, but usually the dyspnea predates the mood disorder. And again, very common, often missed by us, often untreated. So the management is obviously to address and reverse any underlying causes. So pulmonary edema, pleural effusion, PE, pneumonia. When you can't find a reversible cause, symptom relief becomes the main objective of therapy. And I just want to make the point that feeling like you can't catch your breath is among the most distressing symptoms a human being can have. People describe it as feeling like they're drowning, feeling like they're suffocating. It's terrifying. You can't think about anything else, and it needs to be addressed. The linchpin of treatment for dyspnea is opioids. And this is a true-false question. Oral or parenteral opioids remain the standard therapy for dyspnea not relieved by treatment of an underlying condition. The answer is true. These are by far the most studied and most commonly used class of drugs for relieving dyspnea. That said, I often encounter pulmonologists who think that opioids will kill people with pulmonary disease. So you may need to educate your consultant on this. The mechanism of action is thought to be central modulation of the perception of dyspnea. Incredibly effective. Another question, nebulized opioids have been shown to be effective treatments for dyspnea. That is false. Nebulized opioids are only effective if they reach blood levels that you would need an oral or parenteral or sub-Q dose to achieve. So going to the trouble of nebulizing an opioid and putting the patient through the nebulizer treatment, not necessary, not helpful. So a big barrier to the use of opioids as first-line therapy for dyspnea is fear of respiratory depression and accelerated death. Is that true or false? Yeah, it's true. This fear is very widespread, but has been found to be unfounded in several large randomized controlled trials. With proper titration, underline 3 times, start very, very low and go slow in terms of titration, opioids relieve dyspnea. So what do I mean by starting low? How low of a dose would you start an opioid naive patient on who has dyspnea? Really low, 2.5 milligrams. Far less than you would even think about for pain. And in fact, the only way you can give 2.5 milligrams of morphine is to use concentrated liquid morphine, Roxanol. You can't get it in a tablet. You can get it parenterally, but if you're trying to give it orally, you have to order the concentrated liquid. It's called Roxanol. And it's a half cc, is 2.5 milligrams. So just to reinforce the safety of this, these are all the professional organizations that advise the use of systemic opioids for relief of dyspnea, with all the appropriate cautions regarding starting very, very low and titrating up very, very slowly. There's some evidence of benefit from getting people reconditioned through exercise. The use of a handheld fan is remarkably effective, blowing air on the face. Nutritional support just to counteract some of the muscle wasting and weight loss that's common. Acupuncture has some recent very promising studies. So if you have access to that or your patient has access to it, it may be worth trying to get people not to rest in bed. And for a limited number of patients, pulmonary rehab is recommended. It's very expensive and Medicare only covers it in limited categories of eligibility. So this is the summary. Environmental modifications, such as if somebody has to walk upstairs to go to sleep, maybe move the bed downstairs, put grab bars in the bathroom over the tub opposite the toilet, use the fan. Only if someone is hypoxic on oxygen saturation is supplemental oxygen helpful, or non-invasive ventilation. And as I said, very, very low dose opioids, much lower than you're accustomed to prescribing. 2.5 milligrams to start every 4 hours or preemptively prior to walking to the mailbox. Titrate up to relief. Once you're on a stable dose, then switch to long-acting morphine or any other long-acting opioid with rescues as needed and prior to activity that reliably causes shortness of breath. So Mr. B says he is too nauseated to eat. What are the most likely causes? We have him on opioids, and he started out constipated. Hint, hint.
Opioids cause nausea.
Yeah, they sure do. And so does constipation and impaction. So common things are common. Important to know about opioids that some side effects tolerance develops. In other side effects, tolerance never develops. So tolerance develops over a 3 to 5 day period to nausea. And if you can reassure patients that nausea that develops when they begin an opioid will get better, and you can give them some metoclopramide for that symptom at the outset, they can often weather that period. If they think it's permanent, they won't stay on the medication. What other side effects of opioids does tolerance develop to? Respiratory depression. Okay, so the only way you're going to cause respiratory depression in an opioid naive patient is if you give way, way too much in the initial dose. If you start really low, respiratory depression is not going to be a problem. If your patient has been on opioids and is tolerant to opioids, you again would have to give way too much to cause respiratory depression. So this has much more to do with our skill or lack of skill in prescribing this category, this class of analgesics, than it does with intrinsic properties of the drug. So nausea is, like dyspnea and pain, subjective. It can be caused by multiple stimuli of the GI lining, chemoreceptor trigger zone, the inner ear, the cerebral cortex. There's all kinds of contributors to nausea: taste, smell, emotion, drugs, carcinomatosis, abdominal organs, GI distension, dysmotility, inflammation, inner ear problems, and they all have different neurotransmitters that mediate them, which is why there's this at least effort to try to match the cause of the nausea with a treatment that will affect that particular set of neurotransmitters. So vestibular symptoms like that people get like on a boat, or car sickness, you wouldn't manage that with dopamine antagonists. You would manage that with either acetylcholine antagonists or antihistamines, because those are the neurotransmitters that are involved. And On the other hand, very often we end up using multiple agents that target multiple neurotransmitters to get intractable nausea under control. So the general approach, as always, is to reverse the reversible, reassure the patient, try to reduce the stress level in the room, improve the environment, particularly noxious odors, make sure that the patient is receiving good oral care, hydrate. If you're trying to get them to eat, start very minimally and go up gradually. Select your drug based on what you think the pathophysiology or pathophysiologies might be, and consider combination therapy, as I mentioned. And here's the table. The dopamine antagonists, that's Haldol, metoclopramide, the serotonin antagonists, ondansetron, granisetron, both quite expensive, but first-line drugs for chemotherapy-induced nausea and vomiting. Note that they are both associated with QT prolongation. Antihistamines for vestibular vomiting, Benadryl, Meclizine, Vistaril. Remember, these drugs are highly anticholinergic, and if you're using them in older people, you may be causing all kinds of problems: constipation, urinary retention, delirium. So you have to think about that as well when you're using antihistamines in our patient population. Anticholinergics like glycopyrrolate or scopolamine, same, highly anticholinergic. And prokinetics like metoclopramide, only to be used if there's delayed gastric emptying, basically. They're associated with tardive dyskinesia and not trivial in older patients. Steroids are remarkably effective. What they do is reduce swelling and inflammation. Obviously, if the person has increased intracranial pressure, they reduce that. They're also quite effective with chemotherapy-induced nausea and vomiting, and it's often given at the time of chemotherapy for that reason. Somatostatin analogs, octreotide, extremely expensive. It is indicated to reduce bowel secretions in case of usually partial bowel obstruction, but kind of as a last resort. Cannabinoids, getting easier to find and use, quite effective. There are multiple cannabinoid receptors in the central nervous system. THC is antiemetic. It's also an appetite stimulant, also may improve mood, but it can make people sleepy or more likely to fall. So again, you got to think about your patient and their other risks. And neurokinin antagonists, substance P, incredibly expensive, will only be ordered by a medical oncologist for highly emetogenic chemotherapy. So about a month later, Mr. B's daughter calls and says her father is not eating and has lost 10 pounds since he saw you last. And I'm sure you've all experienced this. This is extremely distressing for families when patients stop eating or are not interested in eating. It speaks to all of our human impulses to nurture and feed that come from when we raised our own children, when we were nurtured and fed as children, and families will feel as if they are failing their loved one if they can't get them to eat. So there's anorexia is loss of appetite. Cachexia is loss of weight, and there's two types, primary and secondary cachexia. Secondary cachexia is weight loss solely due to inadequate intake. And that may be because of oral ulcerations from chemo, or head and neck cancer, or malabsorption, or anorexia nervosa, psychological issues. And when possible, these causes potentially are reversible. Primary cachexia is a consequence of serious illness and what is basically a chronic inflammatory syndrome that causes loss of appetite. If anyone here has ever had a bad cold or had the flu, you notice that you're not hungry. You're not hungry because your whole body is inflamed and it suppresses appetite. And is very common, unfortunately, in frailty, just old people who lose weight without trying to. It's very common in dementia, in infection, just like the flu, in end-stage organ failure, and extremely common in cancer. And one of the things that's really important to point out to families is that the person isn't eating because their body can't make use of the calories, because their body is doing other things. They can't make use of them, and forcing food makes them sicker, makes them feel sick, makes them want to vomit, may cause them to aspirate. So it requires quite a bit of coaching and support for families to get people to accept that not eating is a normal consequence of some of these progressive serious illnesses. So clearly, like everything, we want to rule out and treat reversible etiologies. We really want to understand to what extent the patient is disturbed, not being able to eat. I will tell you that my patients are really disturbed by the harassment they're getting from their families. They're constantly under pressure from their families to eat, and it gets hard for them to tolerate that. But if the patient, him or herself, is not distressed about it, that may be your signal to try to educate the family about the reason for it, and to reassure, and that the patient is not starving. If their body could use the calories, they would be hungry and they would eat. But if the patient says they're distressed by it and it's affecting their well-being and their quality of life, these are the drugs you can try. So Megace, Magestrol acetate, a progestogen, takes about 6 to 8 weeks to have impact. It doesn't cause increase in muscle mass, only about 15% gain any weight, and it is associated with an increased risk of blood clots and death. So it's not trivial. So the benefit has to outweigh that risk in terms of the patient's sense of well-being. Corticosteroids are very, very helpful and very effective, but as you know, have numerous extreme toxic side effects. And so you can really only use them for a short period of time. So we tend to reserve corticosteroids for people who have weeks to live, not months. Cannabinoids are a great appetite stimulant, little evidence that they help with weight gain, but I think they may take pride of priority over Megace in the near future because they're safer than Megace. So we're coming to the end. I can't believe it. I have 12 minutes left. Incredible. So here's a patient case, 85-year-old man with COPD and lung cancer, wants some help with shortness of breath. He was breathing at 30, having difficulty finishing full sentences, has coarse breath sounds and some crackles at the right lung base. He's satting at 92% on 2 liters. You think he would benefit from a low dose opioid, then you give him 2 milligrams of IV morphine. When you come back to reevaluate him in 20 minutes, and by the way, you shouldn't come back, you should stand there. Why should you stand there? This patient is opioid naive. He has COPD. It's unlikely that 2 milligrams would be enough to cause respiratory depression, but do not walk away from the bedside if you're giving parenteral opioids to an opioid naive patient with lung disease. You have to just stand there and make sure they're doing okay. So, but it will take 20 minutes for the drug to take effect on the dyspnea. So when you ask, when 20 minutes has passed, how are you feeling now? Do you ask or do you do some test to know whether the morphine was effective? Anybody know?
I think both. You can assess respiratory rate and work of breathing, but you can also, and and his speech, but you can also ask him if he feels less dyspneic.
Right. So these are the options. And the right answer is D, ask the patient. They may have a decrease in respiratory rate. They may find themselves more relaxed. The central perception of dyspnea is what gets better. But the only reliable measure of the degree of dyspnea is what the patient says it is. There are patients who don't experience a decrease in respiratory rate, but do experience an improvement in the dyspnea, again, because of that central effect on the perception of dyspnea. So the right answer is ask the patient. And here's another case, a 71-year-old with metastatic lung cancer complaining of constipation for a week. She's been on extended release morphine for about 2 weeks. She's taking a laxative, but says it's not working. This is the first time she has ever been constipated for this long. Which of the following would not be an effective bowel regimen for this patient? Easy question.
B.
Yes, very good. Okay, so the take-home points are that symptoms are really common during serious illness. They cause a lot of suffering and they are treatable. So as physicians, it is our obligation to know how to treat them and to treat them safely. Management requires not only assessment and reassessment, but a lot of patient and family reassurance, support, and education. And just little takeaways: constipation, prevention, no colace, nausea and vomiting, consider choice of antiemetic based on pathophysiology, and consider cost. Anorexia and cachexia are often not reversible and a sign of disease progression. Only treat if the patient is distressed by the symptom, if it's a patient with coexisting serious illness. And the dyspnea self-report is the only truly reliable measure of whether it's getting better or not. So I'm very proud of myself because I usually go over, but I finished early. So does anybody have any questions?
Thank you. That was very, very useful. I've seen an abdominal X-ray being ordered in patients with constipation. Other than ruling out an obstruction, is there any use to getting an X-ray?
No, but that is the reason to rule out an obstruction. I mean, if the patient is impacted, they're obstructed. So you don't need an X-ray to prove that. You just need to disimpact them using digital disimpaction, glycerin, or Dulcolax suppositories, and warm tap water enemas. And understand that sometimes those warm tap water enemas have to be repeated 6 times because there's a block of concrete sitting in the rectum.
And what would be the interval between repeating them?
Well, you know, it's sometimes hard on the patient. If you can get the nurses to do it continuously, that's the best. You want to, have you heard the term high colonic enema? We always think that means high in the colon. It doesn't mean that. It means at the ceiling. So making use of gravity.
Okay.
Bag on a really high pole, so that there's a little pressure of the water coming in to try to break up what is, you know, often very solid and dry if it's been there for a long time.
All right, thank you.
I had another question. So in patients who develop overflow diarrhea from impaction, do you have any strategies you recommend? Because it seems counterintuitive sometimes to give them, when they're having overflow diarrhea, to give them more laxatives.
Yeah, that is almost always due to diarrhea moving around an obstruction. Almost always. So it's sort of the early stage of that stercoral ulceration I told you about, that basically the colon is becoming inflamed around that impaction, and the inflammation is pouring fluid into that location, which is causing diarrhea. So again, you've got to disimpact. And if the impaction is high, usually it's not. Usually the impaction is quite low. You may need help from GI to disimpact, but most of the time it's quite distal and it's just not giving up.
Thank you.
Another question on the subject of constipation with with stimulants. Is there any concern at all about developing bowel dependence on them?
It depends on your patient. If they're a person who's pretty much always going to be constipated, both because of relative immobility or restricted diet or the drugs they're taking, you're just going to have to accept they're going to be on laxatives for the rest of their life. If it's someone with more of a mood disorder related constipation or eating disorder related constipation, you would want to use it only to get somebody moving again, and then go back to bowel retraining, go back to diet, go back to fluids, go back to exercise, try to restore a younger, healthier person to a normal set of bowel habits. That's the group in which I would worry. Many older adults require some level of laxatives every day, particularly those on opioids or other anticholinergic drugs, or receiving drugs that cause neuropathy, like chemotherapy, because it also causes neuropathy in the gut.
Okay, thank you.
Yeah.
Yeah, and you have a loaded question on the chat, which
No pun intended.
But I will, it requires quite a conversation, but I will say it. But what would your approach be to family members who would like to explore the option of enteral feedings and PEG tube placement in an anorexic patient?
So that's a great question. And like all great questions, the answer is it depends. So if my anorexic patient is anorexic post-op and is expected to recover, I would go with it. If my anorexic patient is anorexic because they have end-stage dementia and can no longer remember how to swallow and have no interest in food, I would spend a lot of time explaining that the inability to eat is a sign that the patient is dying from the dementia and that they can't make use of the calories anymore. It's the body telling us something. That's very hard because, again, families feel like they're starving their loved ones, that they should do something. I will tell you that the rate of tube feeding in end-stage dementia has dropped by about 70% in the past 10 years. So that, back when I was your age, everybody got it. Everybody got it. And, it was impossible to talk families out of it. It's much less common now. Because I think clinicians are more often having honest conversations about what loss of appetite means in someone with an end-stage disease. It's a sign that the person is starting to die. And force feeding is not only uncomfortable, but risky. But sometimes families want it anyway. And then we do it.
Is Dulcolax given orally a good laxative?
You can give it orally or as a suppository. It tends not to be enough by itself. You can certainly start with it. You can always start with something, double the dose. That doesn't work, add something else. Again, think about cost. That table had the costs of the different agents. These are over the counter, so your patient is paying for it, him or herself.